Hi, everybody. I'm Dr. Ellie Stein with your video tip of the month for April 2025. This is a really important topic, which I think will be of interest to many of you. It's called What Really Causes Chronic Depression? Now, as usual, this video tip is being published at the same time as a blog post with a similar name. In the blog, you can read more of the gritty science details, and you can check out the peer-reviewed references that I read and used to create this video tip. In it, I am going to share with you a compelling new model of depression, one that explains much of the biology of depression and explains why and how various different antidepressants, including ketamine, work. Spoiler alert, this model has nothing to do with neuromodulators like serotonin. So a little bit of background. Throughout my entire career in medicine and more recently in psychiatry, I have been taught that depression is due to a deficiency of a group of molecules called monoamines. These include now familiar names like serotonin, noradrenaline, and dopamine. The most commonly used antidepressants, the selective serotonin reuptake inhibitors, or SSRIs, act on these molecules to increase their availability at the synapses or the nerve endings. And to a modest degree, these drugs do help some people feel better as long as they stay on the medication. Unfortunately, they're far from perfect. Many people continue to have residual symptoms, especially things like cognitive dysfunction and unrefreshing sleep, even on medication. Most people experience side effects that they do not enjoy, things like emotional blunting and decreased libido. And unfortunately, these drugs only work about half the time. Now, there's been a growing cacophony of voices questioning whether this monoamine hypothesis of depression is correct. And I'll give you now some reasons why people have been questioning it. Serotonin levels in the synapses increase within hours of taking an SSRI antidepressant, things like fluoxetine, paroxetine, citalopram, etc. But the clinical benefits take 4 to 8 weeks. So there's a big mismatch between what's happening at the cellular level and what patients experience. Now, when serotonin is experimentally depleted in healthy subjects, you would expect them to get depressed if the monoamine hypothesis was correct, but in fact, this doesn't occur. Similarly, people who have genetic variants which cause them to have lower than average serotonin levels, they're actually resilient to depression instead of suffering from it more often. So again, this doesn't quite fit with the monoamine hypothesis. One of the big concerns is if serotonin and the other monoamines are central for mood, then why do the drugs only have an effectiveness rate of 15% above placebo levels? Meaning, if you give people with depression a placebo, about 35 to 40% of them feel better. And if you give them an active drug, that number goes up to about 50 or 55%. Now, as if this wasn't enough, I think what's really put the nail in the coffin of the monoamine hypothesis is the development of new effective antidepressant therapies that don't act on monoamines at all. So what is an alternative hypothesis? Interestingly enough, the evidence for this came from the observation now for decades and decades, maybe up to 100 years, people have observed there's a strong connection between stress and depression. Now, this doesn't mean that every single person exposed to stress gets depressed. Of course, this is untrue. But if you look statistically at large groups of people, those who have experienced chronic stressors, especially during childhood, have a significantly increased risk of developing depression. And with modern technology, we now have an understanding of why this is the case. So I'm going to give you the quick summary. Prolonged stress increases cortisol levels. That's why cortisol is called the stress hormone. Prolonged elevated cortisol damages and even kills neurons in the memory centers of the brain that are here on the sides of our head. They're called the hippocampi, hippocampus for singular. So basically, when we're under chronic stress, our ability to remember and learn new things decreases. Furthermore, cortisol decreases the growth of new neural connections, and neuroplasticity, or learning, relies on the development of new neural connections. So simply put, chronic stress shuts down neuroplasticity and makes it harder to learn and change. It does this, it's quite complex, but to kind of simplify it, it does this by decreasing the production of several critical molecules required for neuroplasticity, the most famous of which is called brain-derived neurotrophic factor, or BDNF. So what is the biology behind the subjective experience of depression? If you experience depression yourself or have in the past, and it's extremely common, as many as 20% of adults have had an experience of depression, you'll know that you tend to get stuck in a rut of negative thinking. You're more likely to notice and respond to negative than to positive. This tends to include information about yourself, leading to low self-esteem, information about your life, leading you to be kind of despondent and pessimistic, and information about the future, leading to hopelessness. The stress response is involved in this negativity bias because noticing and remembering danger is critical for survival. So remember, stress tends to get a bad name, but the stress response actually keeps us alive. It's critical. We also have something called the intrinsic reward pathway. So when we do something fun, connecting, creative, it makes us feel good inherently. We don't have to try to feel good. We just automatically do. And this is due to dopamine. And unfortunately, the dopamine pathways are underactive in depression. So therefore, people who are depressed don't get those normal dopamine mood elevating hits that, say, healthy people get. I always hesitate to use the word normal because what does that mean? So people with depression don't get those dopamine hits that other people get. And as a result, life feels dull and unenjoyable. And maybe due to the negativity bias, people with depression are more likely to pay attention to and be vulnerable to stresses that do happen, everyday stresses in life. They tend to see stress everywhere, and they perceive stress as something they can't overcome. In a separate video, I've talked about how the mindset about stress actually impacts our biology. Finally, cognitive function, ability to pay attention, concentrate, and remember are all impaired in depression. So this makes people with depression less flexible in their thinking and less able to take advantage of opportunities in life. Now, one of the turning points in our understanding of depression, and I would say in the whole field of psychiatry, came when it was discovered that ketamine, a drug usually used as an anesthetic, could cause people with long-term stubborn depression to feel better very quickly. Why is it so interesting? It's because the primary effects of ketamine in the brain have nothing to do with monoamines like serotonin. What they have to do with is neuroplasticity. If you compare serotonin reuptake inhibitors to ketamine, here are some of the key differences. Serotonin reuptake inhibitors act to increase levels of serotonin at the synapses. Ketamine acts on a different system entirely called the NMDA receptor. Ketamine has a higher response rate than serotonin reuptake inhibitors, especially in the people that are the hardest to treat, the people with who have what we call treatment-resistant depression. And in psychiatry, this is the most difficult, most challenging, in depression at least, the most challenging group of people to work with, because by definition, they've tried several things already and nothing has worked. When we're using SSRIs for these treatment-resistant patients, only about 10 or 20% get further improvement. When you use ketamine, it's as high as 50%. So that's a very big difference. Ketamine acts much, much faster. It can act in hours. There's an immediate effect that I'm going to discuss in a minute. And then there's a more prolonged effect that is experienced over 1 to 2 weeks. And as I've already mentioned, SSRIs and other antidepressants typically take 4 to 8 weeks to kick in. Ketamine and other drugs like it are used only occasionally, like maybe once a week or once every couple of weeks, whereas antidepressant drugs need to be used on a daily basis. So for those of you who are interested in the science, I'm going to dive a little bit right now into how ketamine works. Ketamine is now one of a new class of drug that's been given the name psychoplastogens. So psycho meaning it's acting on the brain, plasto meaning it has to do with neuroplasticity, and gen meaning it's an agent that causes neuroplasticity in the brain. Other drugs in this category include MDMA, psilocybin, and LSD. So drugs that we think of maybe as hallucinogens and which in different places around the world are sometimes not even available, right? Because there's still a stigma about these drugs, which have been considered drugs of abuse in the past. But where legally permitted, these drugs are now being used for something called medication-assisted psychotherapy. So here's how it works. You take a dose of the drug. Sometimes it's an injection or an infusion. Increasingly, there are tablets that you put under the tongue. And it opens a neuroplastic window, meaning for several hours after the dose, the brain is in a state in which change is more possible than usual. Now, during this time, if you work with a skilled psychotherapist who can guide you through a process of identifying and reevaluating your beliefs and assumptions and help you understand the experiences, you can develop new perspectives quite quickly. You can get unstuck in the thinking that's been keeping you depressed. Now, these therapies are most often being used for depression and PTSD. These are two severe mental health conditions in which getting stuck is a big part of the picture. Again, a bit of a sciencey, interesting fact is that ketamine, if you take it in the moment, has two different effects. The almost immediate effect can be measured at the molecular level, and it happens within minutes to hours of taking a dose. Now, these changes are thought to be related to the almost immediate sense of well-being that some people report after taking ketamine. Then there's a second, slower response that builds over days to weeks. This is the actual neuroplastic change happening in the brain. It's slower because it takes time for all of the infrastructure and construction to take place to build these new synapses. The effects of one dose of ketamine, or more recently, kind of an analog of ketamine called S-ketamine, can last 1 or 2 weeks. Now, ketamine acts, as I mentioned, by binding to the NMDA receptor, and it has no direct impact on monoamines. When the NMDA receives the message from the ketamine, there's an increase in glutamate, the neurotransmitter glutamate throughout the brain. This leads to an increase in several molecules. The two most maybe significant, or the ones that are best known, are BDNF, which I've mentioned before, and another molecule called mTOR, the mammalian target of rapamycin. Now, BDNF is the molecule that gives the signal to the brain, kind of like permission to go ahead with neuroplastic change. mTOR mobilizes the protein reserves necessary to build the new neural connections. Now, you might be thinking, okay, so ketamine acts on neuroplasticity, but is this enough evidence to say that we need to reconsider our whole understanding of chronic depression? I believe the answer is yes, for the following reason. Research has now been done on virtually every effective type of antidepressant, and they all act on neuroplasticity. Here is a list. So, antidepressant medications like selective serotonin reuptake inhibitors and even the older tricyclic antidepressants cause neuroplastic change. They increase BDNF levels. Lithium treatment for bipolar disorder increases the thickness of the gray matter in the brain. That's the outer layer. This means that new neural connections are being formed because our gray matter is basically made up of synapses. Cognitive therapy and behavioral therapy also leads to measurable changes in the size and activity of brain regions as measured by functional imaging. And believe it or not, we've known this for almost 30 years. Dr. Jeffrey Schwartz showed this effect in patients he was treating with talk therapy for obsessive compulsive disorder, and he was able to show structural brain changes as a result. Electroconvulsive therapy. Now, many people are scared of it and feel like it's archaic and shouldn't be offered. I have to tell you that it remains one of the most effective antidepressants out there. And a recent study showed that it's about equally as effective as ketamine. So that speaks kind of well of ketamine, that it's matching the benefits of ECT, which up until now has been at the top of the heap in terms of effectiveness. ECT, it turns out, is a very strong promoter of neuroplasticity. It increases the number of neural connections in the brain. Now, exercise is a powerful antidepressant, and guess what? Exercise boosts BDNF and neuroplasticity. Finally, even emerging therapies, things you might not have heard of, like transcranial direct current stimulation, where you're basically zapping the brain with specific electric current frequencies, and photobiomodulation. This is red and infrared light therapy. They both increase BDNF levels and promote neuroplasticity and new learning. So this is all well and good, but maybe you don't have the energy, the financial resources, or the research capabilities to find a ketamine-informed therapist or to try one of these fee-for-service therapies. They can be quite expensive. So you may be wondering, is there a DIY approach? Could I begin a daily neuroplasticity-based practice, and would it help my mood? In my experience, and I've been delving deep into this field in myself, with my medical patients in the past, and now with my online community, it's been over 10 years. And my answer is a resounding yes. What I have observed in myself, even though I wasn't doing neuroplasticity-based practice for mood problems, but nevertheless, you know what? My attitude and my mood and my mindset have all improved. I've noticed in people who came to me and were practicing neuroplasticity for chronic pain, many of them reported that even though they weren't targeting mood, they hadn't really thought about it because they had only heard about neuroplasticity as a treatment for pain. Nevertheless, many of them have experienced very substantive improvements in depression. Many people have been able to decrease or even come off antidepressant therapies. So this suggests that neuroplasticity-based practice is generalizable. If you target one symptom, it's possible that other symptoms that you hadn't even thought of may also benefit. Now, although there is no science-based evidence for this statement that daily neuroplasticity-based practice is an effective antidepressant treatment, what I'm reporting to you is based on my own observation and experience over the past 10 years. But there is something that's a little bit close, and that's the field of mindfulness meditation. So mindfulness meditation is one of the best researched body-mind or mind-body therapies of all time. There's literally hundreds, if not thousands, of studies. And many of them involve neuroimaging, PET scans, SPECT scans, etc., functional MRIs. And what they consistently show is strong evidence that a daily mindfulness practice enhances neuroplasticity. So if you're thinking about trying a neuroplasticity-based practice for mood, what are some of the keys? Now, if you listen to some of my other videos, I go into this in much more depth, and my Rewiring Your Brain for Better Health beginner course that I've just released, of course, also goes into more depth. But here's kind of a summary of the things that you might want to consider. So first of all, you want to practice daily or almost daily, and that practice should be comprised of about an hour. You don't have to do an hour all at once, but if you add up all of the different practices you do over the course of a day, you're looking at about an hour to be confident that you're going to benefit. The practice needs to entail focused attention. That is essential for neuroplasticity to take place. You need to kind of observe yourself and consistently change your thoughts, feelings, and behaviors to ones that are congruent with your goals. You want to become expert at calming and safety practices so that your brain understands it's safe and the stress response is not needed. You want to purposely do things in your day that are fun and that make you feel good. You want to incrementally and carefully, with instruction, increase your exposures to triggers, things that are currently causing you symptoms. Now, don't kind of rush off in all directions and do this. There's a specific protocol that I recommend. You want to work towards your life goals. You can do all the practice in the world, but if you don't actually start working on the things you hope to achieve, of course, they won't get done. And finally, you just want to practice, practice, practice. The bottom line is that neuroplasticity-based practice is an active treatment. You have to change your thoughts, feelings, and behavior on a consistent basis to rewire your brain. That's just how it works. It's not easy. It's not magic, but it's free, it's accessible, and it can be very effective. Some final comments. Please don't throw the baby out with the bathwater. Antidepressants, and yes, even the dreaded ECT, still have a prominent place in the management of depression. They can be life-saving. So if you are severely depressed, please don't go off your medication without careful discussion with your psychiatrist or family physician. And please start a neuroplasticity-based practice first and only change your medical treatment if it becomes obvious to you that you don't need it anymore. Antidepressants can get people out of very dark places. And in doing so, they can provide enough relief and a little bit of an energy boost so that you're then in a position to consider a treatment like neuroplasticity-based practice, which takes some effort, right? You can't do it if you're in the pit of depression. But know that antidepressants are a band-aid. They don't significantly change the underlying brain structure and function that is causing depression. And for this reason, most people who have chronic depression, meaning they've had 2 or more episodes, are recommended to be on antidepressants for life and to suffer all the incumbent side effects that are so common with them. On the other hand, neuroplasticity offers an option, the possibility of partial or full recovery rather than a temporary band-aid. By rewiring your brain on an ongoing basis, you may, if you're lucky, be able to decrease or even get off your antidepressant medication and free yourself from the bothersome side effects they cause. If I've whet your appetite that neuroplasticity may have something to offer for you, my suggestion is that you go to my free educational videos page. You can access it through the free resources tab on my homepage. There you'll have access to several free videos on important topics like neuroplasticity, sleep, mindset, and more. You'll get a sense of whether you like my approach and whether you think neuroplasticity might have something to offer you. If you do, please go to my sales page where I list the various course options available to you. I wish you luck in your journey of overcoming depression.